It's 11 o'clock. Let's get started. So welcome, colleagues, to KSU's Research with Relevance Friday features. We are back again for the 7th and final episode of the Chairs and Directors Showcase this semester. And today we will be featuring Dr. Monikanandan, who is the Director of Strategic Partnerships and Social Impact in the Wellstar College of Health and Human Services. Welcome to you, Monica. My name is Phaedra Corso, and I'm the Vice President for Research here at KSU. And our goal with these features, as we've been doing for the last couple of years, is to highlight some of our outstanding faculty here at KSU and to stay engaged as a community of scholars and researchers. So a few housekeeping tips before we begin. First, please make sure your mics are all muted, which I see that they are. You're welcome to unmute when we start the question and answer session. If you want to focus on a specific speaker like Monica, you can click on the 3 dots next to her name and this will pin her and make her larger on the screen in front of you. Finally, I do want to mention that this episode is being recorded and it will be available to you through Kennesaw State's Office of Research and through our YouTube channel in the next few days. So the schedule for the next hour, we will watch a video giving an overview of the research of our featured guest, Dr. Monikanandan, and then we will do the live interview and audience Q&A. So if you have a question after the video, feel free to either raise your hand and I'll call on you. You can put a question in the chat. Chat function is just fine. You can interrupt us. We'll be okay with that as well. So let me start with an introduction of our guest. So Monica joined Kennesaw State in 2012. She became the Director of Strategic Partnerships and Social Impact in 2018. She has a diverse academic and professional background, having earned a PhD in social work from Florida State University and a master's degrees in social work, healthcare, and finance. And again, welcome to you, Monica, and let's watch a short video that was prepared with the help of Megan Lowney.
My name is Monikanandan, and I am the Director of Strategic Partnerships and Social Impact for the Wellstar College of Health and Human Services. My very diverse and cross-continental academic background, training, along with experiences in accounting, finance, service marketing, healthcare, gerontology, and social work has taught me one thing for sure: how much I do not know. It has also taught me to view issues, situations, problems, challenges, and opportunities from different angles and perspectives. Challenges and opportunities are like a kaleidoscope, constantly changing based on the vantage point one is looking from. Academic and work experiences have also taught me to naturally think in inter- and transdisciplinary manner, which has influenced my 2 research themes and orientations. 1, interprofessional collaboration, and 2nd, social innovation and entrepreneurship. I work with disparate interprofessional and interdisciplinary teams at Kennesaw and outside, and as we embark on projects, we uncover other layers of the onion that need to be understood and addressed simultaneously. Hence, several projects and research endeavors are occurring concurrently with students and faculty from different disciplines. Particularly, I would like to share 3 research or grant projects. I will first discuss the details of a grant-funded research examining the mental health of academically high-achieving high school students. Second research project is understanding mental health help-seeking behaviors of college students. And the third research is identifying potential mental health cases from police incident reports, since all first responders code the 911 calls differently. The first research project used human-centered design thinking methodology to collect data from high-achieving high school students that led to the development of a nonprofit called Youth Centric. A philanthropist provided funding to research the emotional well-being of school students, particularly high-achieving students, wherein graduate students from 5 different disciplines at KSU, they used design thinking tools and social innovation orientation to collect data from over 200 school students to help build the infrastructure of a nonprofit called Youth Centric. To help design the details of the center, we hired undergraduate students from several other disciplines to brainstorm and prototype ideas that will be fleshed out further with the professional architecture, board members of organization, and program staff. The second set of research I would like to share builds on this previous research I just shared. In our community engagement efforts, we have learned that there is a tremendous variability in the help-seeking behaviors of individuals from diverse backgrounds. Our study is available on Georgia Department of Public Health website titled Georgia Opioid Strategic Planning, Multicultural Needs Assessment, and speaks to help-seeking behaviors and recovery journey of individuals from Latinx, African American, elderly, college, veteran, LGBTQ population, along with individuals who are unhoused. Another related study was on college students' help-seeking behaviors in particular and access to care for mental health. There is limited research on online help-seeking behaviors, let alone specific research on college students' online help-seeking behavior. This study identified terminologies that college students utilize with online search engines to seek assistance and or information related to mental health. The most common words used by college students is in the realm of just mental health or mental health help. And some of them use symptoms and diagnosis, which are mostly women students. Some others use either cost words or insurance words, also commonly used by students. Additionally, as a facilitator of a community coalition interfacing with first responders, which is police, fire, 911, in collaboration with several faculty from Wellstar College and Coles College, we are trying to understand how first responders respond to 911 calls that have behavioral health underpinning. We've also learned in this endeavor that the codes used by 911, fire, EMS, dispatchers, and police are not consistent. Hence, at this point in Georgia, and probably nationally, we are guessing the number of behavioral health related calls received by 911 and responded to by police and fire. These community collaborations are giving rise to several questions concerning the issue of mental health. How these professionals respond, what occurs at the site, how many calls occur each year, what is the disposition of these calls. Consequently, we have signed a memorandum of understanding with the county government to receive copies of over 50,000 cases from police incidents reports to answer these questions. We are using neural network analysis, algorithms, and primary coding by hand to see if we can uncover patterns in the data that can help predict the incidence of potential behavioral health calls. We have identified over 180 codes so far and grouped them into categories of diagnosis, behaviors, medications, and crimes. The purpose of all these projects are to engage in collective impact thinking, use and build a system architecture design for behavioral health, travel upstream in the behavioral health space, and be proactive. Connect the nodes of different systems in primary, secondary, and tertiary prevention in behavioral health. Finally, to guide local and state policies where possible to enable better design and delivery of services in the behavioral health realm. I'm truly grateful and indebted to my KSU faculty partners, students, particularly GRAs, as well as global collaborators on projects we have completed together and are completing. Without the shared vision, passion, and contributions of each one of the partners, we would not be sharing the timely nature of our research endeavors today.
Wonderful. Thank you. Um, wonderful research that you're doing, Monica. You're such a shining example of our fourth pillar, which is community and involving community in the work that you do and doing research that matters for our community. So I just appreciate you so much.
Thank you. Thank you.
I want to make sure that we can hear you. Okay, so I'm going to just start with some pretty general questions about you, and then we can dive into your research. So you, in the video, you talk about your experience in accounting, financing, social work, and gerontology. I find this to be such an interesting mixture of areas, and I would love to know kind of why you have that large umbrella of experience in education, and then how did you come to KSU?
So growing up in India, when I was growing up in India, I won't tell you how many years ago that was, we used to have a handful of tracks or majors. So either it was literature, language, what we call the arts, or you had the sciences with engineers and doctors, or you had what was called commerce, business. And I knew I didn't want to do the first two, so the only default was commerce. Got my degree, loved not math, but accounting more than math. Loved it, worked in the field, but I think I've been a systems thinker all my life and realized that it wasn't fulfilling me the way I wanted. So I wanted to use accounting in healthcare. Came to the US, got into healthcare, got my master's, and still in using my business degree in healthcare, couldn't wrap my arms around the complex issues we were dealing in healthcare. Stumbled across social work in one of my internship sites. I didn't even know that was a profession, and said, I think I found my calling. I think I can now blend my management, accounting, finance background with social work to address healthcare issues more holistically.
Thank you. Thank you for that, Monica. And I love that you tell the story that you didn't know this is what you wanted to do, but then you stumbled upon it, because I think for so many of us, that's really how we come to find what really drives our passion, right?
Absolutely, absolutely.
Okay, so let me just do a follow-up question to that. Is so you come from India and you have this area that you stumble into. What about KSU brought you here?
So I think it was, honestly, to be very, very honest, the dean at that time, Dr. Richard Salvo, was a futuristic thinker, was an innovator. And at that time, I think a few years before moving here, social innovation and social entrepreneurship became my new calling, so to speak. And when I met him, and his vision for health and human services provided me with a venue to make this a reality, my dream of social innovation and entrepreneurship within social work a reality. That's really what brought me here.
Yeah, good. So in the video, you use a couple of terms that I'd love for you to define for us a little bit more, and that is the difference between interdisciplinary and transdisciplinary.
So Fedra, I'm going to give you my working definition, because there are lots of definitions out there. The way I view interdisciplinary, mostly interprofessional collaboration or interprofessional education and practices, where different professionals learn about each other's roles and values and skills. They learn from each other also, and then they use this knowledge, this new acquired knowledge, they use this to then plan interventions for their end users, or plan education, as the case may be, if you're looking at interprofessional education. Transdisciplinary goes a step further. It is inter in nature, but it breaks down context. I shouldn't say breaks down. It recognizes context, culture, natural culture, social culture, and of course, the other forms of cultures that exist beyond professional culture. It breaks down those barriers. And if I'm thinking of new theory development, occurs in this space where even with interprofessional, I am still a social worker, you are still a public health professional. Those identities completely dissolve in transdisciplinary action. And consumers and end users are almost equal partners, not almost, always equal partners with the scientists and the other professionals.
Mm-hmm. Good, thank you. That I find that really fascinating. It's almost like we talk about interdisciplinary research all the time. Here in this office, we have broad themes, as you know, here at KSU, the 4 interdisciplinary themes, but the transdisciplinary, I think, in the way that you described it, allows us to take the interdisciplinary work and maybe even create new fields almost.
That is right. So NIH has a beautiful definition of community-based participatory research. Mm-hmm. And if you've read that definition, it says the community partners and the scientific community work collaboratively to plan the research, to do the research, to implement any projects. They're equal partners. That's trans.
Yeah, good. And I like that you're using the term of community-based participatory research, because to me that is so much part of our 4th pillar, which is not KSU doing research for research's sake, not us saying to the community, here's the great work we've done, now you do it. It's going to our community and saying, what are your needs and how can we help you? And that's truly what you're doing in the work that you're presenting here. So we've got a hand up already, so I'm going to turn it over to Tyler, who is our Associate Vice President for Economic Development. So I would imagine he would be very interested in the work that you do with community partners.
And I got to say, Monica has been an incredible partner in the 9 months that our office has been here. And Monica, I think you're really unrivaled in your ability to bridge that gap between the academy and the community. And community members that I've dealt with in all walks of life always speak volumes about your ability to convey what's happening on campus, which, you know, it's the ivory tower mentality, the idea that what happens on campus isn't really getting disseminated and used in a practical and relevant way. But community partners rave about your ability to do that, to bridge that gap. And I'm curious, just thinking back on your career, what lessons did you learn along the way in being able to do that, being able to make that connection in a way where folks in the community feel like they're a part of what's going on, feel invested in research and innovation that's happening on campus? What lessons did you learn along the way that you might be willing to share with somebody earlier on in their career who's really struggling to bridge that gap that seems you've been able to do so well?
I love that question. And let me see, what angle I want to use to respond to that. I think something in the video I hope resonates with people in the audience today. And by the way, many of my partners are here too, and I'm grateful to you all. My students are here, my partners are here today. I'm grateful. I would not have been able to do this presentation without you all. So from India, this message is coming from India. Thank you to all my partners. Responding to your question, Tyler, I would say one thing I've realized, and when I approach partners, I think humility is number one. Humility is number one. It's their space, whatever space it is. I mean, I knew nothing about police, nothing. I've been in this country for 30 years. I knew zero about police. And in my last 3-4 years working with them, the amount I've learned from them, I think it's the humility that one needs to bring to any new population you're tapping. I mean, in my previous life, when I was doing my PhD program, I became a CNA. I actually became a CNA in the state of Florida to understand, not as a social worker, the lives of CNAs in long-term care, but to become somebody you're studying is very different than giving them questionnaires, right? And that experience, Tyler, 9 months when I was so-called undercover doing this study, that was the most humbling experience on the planet. No textbook teaches you how to do that kind of research. It was a phenomenological study, and it taught me a lesson of a lifetime. So humility is number one. And like in marketing, which is another background I have, the consumer is always right. So in this case, whoever you're partnering with, their perspective is the right perspective. I think these are the two things.
Excellent. Thank you. I totally agree with everything that you've said. Being in the field of public health, it's the same thing. We go into communities and we are more successful when we listen to our community partners than pretending that we know all when we walk into those settings. So we have a couple of more hands up. Paola, I think you were first.
Thank you, and I hope my connection is good enough. So thank you so much, Monica. As always, very interesting to listen to your other opportunity to do that. I would like to follow up to your response and what Tyler was saying. So my field is requirements engineering, right? And we talk all the time about domain knowledge. And you nicely said, oh, I didn't know anything about police, right? And so I wanted to, you know, like, and I see how humility can play a gigantic role in creating the connection and the trust between you and partners. But I was wondering, on your side, what were you doing to fill that gap in domain knowledge when it happened, and if you had timeline? And so, you know, like sometimes in a project, for instance, in a software development, you have a timeline, and so the time is limited to fill that gap. And so I was wondering, you know, how this time and domain knowledge play a role in your relationship and in your domain.
Let me see if I understand the meaning of domain knowledge. You mean my knowledge of the, let's say in this case, the police? Is that what you mean by domain knowledge? Okay. You've posed a question, and again, I have a greater appreciation for systems designer. My colleague Dominic Thomas is on this call. He's an information systems person. He's a dear friend and a colleague. I've learned so much about systems and systems processing in the last 3 years. And before I answer your question, let me just say, we in social work and in health and human services, we talk about health and human delivery systems. We use the word systems. The irony is that we never talk to systems engineers and information systems people. That is the whole irony. So the word system is used, and I'm a systems thinker. I don't know how to design it. I can visualize it, but I have no idea how to design it. And what I have learned is when I talk to my data analytics and my computer science software engineering people, systems developers and architects, the word architects, before the domain knowledge will come, I am still learning about that domain of systems, information systems. Neural network analysis is a new concept for me. I am not rushing into meeting a timeline here. I'm not, because if I did that, the comprehensive understanding required of all the stakeholders that are engaged in the system, I might miss someone. So right now, I'm really treating this like a luxury. I am understanding. I am just peeling the onion one at a time. I'm not here trying to solve and build a system yet. Years of understanding, because mental health and healthcare and behavioral health is a very complex understand. With grant writing, unfortunately, we are quick to give a solution in 1 month. I should have a proposal in place to fix the mental health problem, right? So grant writing forces us to think quickly. And I'm trying to step back and go upstream. The book Upstream is teaching me lots of patience and always say, I don't know. I'm still finding out. So that's the long answer to your very short question.
Good, thank you. A great question, Paola, and I like the response too. We have a comment in the chat from your colleague, I believe, Monica, where Dominic says there have been billions of dollars spent rushing into these problems with poor results over decades, and that is absolutely the truth. So great. I believe Evelina has her hand up next.
Yes, Monica, thank you so much for your great presentation. I know you have done a lot of work in behavioral health, and that seems to be a common theme among a lot of your interactions with the community from different facets. And I was wondering if you could tell us a little bit kind of about the accomplishments you've seen, especially locally in Cobb County, around behavioral health.
Accomplishments around Cobb County. So I'll give you an example of, I think I'll have to talk a little bit about my journey and how I got into this. Evelina, to tell you the accomplishment. So mental health was not my forte. It was not when I came to Kennesaw. Innovation was my forte. And in my role as a chair, I tried to find new internship sites, behavioral health internship sites for our students, right? Job placements and internship. That's the job of the chair. Make sure that there's a nice repertoire of diverse internship sites. And in that journey, I was hitting brick walls. Like nobody had a comprehensive list, a reliable, comprehensive list of providers in behavioral health. People used to go to United Way and or DBHTD's website for resources, for lists. Well, DBHTD's website is updated, but United Way is updated every 3 years, 4 years. There was no comprehensive place. In that journey, lots of conversations happen in and around Cobb County. And I realized that providers and individuals who make referrals for behavioral health, not only consumers did not know where to look for resources, but even the people who make referrals, like the 911 people, and the providers themselves, LPCs, LCSWs, if you ask them today, where do you go look for resources? There's no single one-stop shop. So what has happened, I think one of the biggest accomplishments has been in this 10-year journey is people are talking about a desire to have a one-stop shop for a resource, updated comprehensive resource list of the entire behavioral health spectrum, which includes substance use disorders, opioid disorders, and mental illness. Have a one-stop shop for that. People are having that conversation in a more candid, open way. That's a big one. The other big accomplishment has been that the study that we completed on, and my colleague is on this call, on the journey traveled by people from diverse cultural backgrounds, the recovery journey they travel from the time they start consuming substances till sobriety and beyond. That study was probably first of its kind for the state of Georgia that we completed, and we are using the findings from that study to guide the state's multi-stakeholder strategic plan for opioid disorders. That's the second accomplishment. And the third accomplishment has been that we got a call from governor's office recently about some of the work we are doing with 911 data and police data. And they would have liked us, if they had the funding, for us to replicate the study across the state because of the 1013 bill that was just passed. So those are initial accomplishments, Evelina, that come to mind.
Hey, thank you, Evelina. I'm going to follow up on that question and ask about the 1013 bill that just passed. And I'm sure you're enthusiastic that this legislation passed, and I'm wondering if you could tell us what are some implications, potential implications for the field of social work in particular, and for your students moving forward.
So this had bipartisan support. It was actually a bill that was passed, I think, this April, signed by the governor. It was a real landmark bill because one of the major tenets of this bill is to have mental health parity. In simple words, what that means is whatever insurance you have, whatever coverage you're provided for physical health, whatever the max limit is, you will have similar coverage for behavioral health needs as well, and you will not have a lower cap. Now that's a huge accomplishment for behavioral health and for students and for social workers. That means that coverage will be better than it has been in the past once the law is implemented. The question is, once the law is implemented. That's one. Second big accomplishment or the tenet of this bill is that there should be increase in the number of healthcare providers, behavioral health providers in the state. Rural Georgia really suffers in terms of access to providers. The third one, if I remember correctly, is access, just general access to behavioral health system, the system that we talked about that doesn't exist. So accessing the system, building a system and ensuring access of all income levels. And the final one is data, access to data and transparency. Those are the four pillars of this law, and the timeliness, all the work we have done over the last 10 years in this realm, this bill will help bring many of those elements to fruition and even scale some of the efforts across the state, in theory. For the students,
Good.
More placements for the students and more jobs upon graduation.
That's right. It's a job security act for certain professions, and I think social work is one of them.
Right.
Yeah. Right. And you know, the downside to the legislation is that the system that is already overwhelmed is now about to be even more overwhelmed, and so that is something that we'll have to be facing as a state.
Right. Absolutely.
We have Kim Hengholt, who also has her hand up.
Hi, Monica. Thank you so much for all the work that you do in the community. We've been partners for many years now, so I'm really appreciative of the work that you do. I do have a question. You do such a great job of involving your community partners and creating that knowledge base to help inform the community about policies and about activism, and just helping with all the wonderful projects and research that you've done. I wondered, we have a lot of faculty sometimes that I hear say that it's difficult to work with the community. There's apprehension there because there's, you know, a lot of obstacles that you have to kind of go through when you're working with community. And I wondered, in all of the projects that you've done, all the partners you've had over the years, what are some of the challenges that you feel like are there when you're doing this community-based research? And then what are some of the things that come from it that are positives, that are really advantageous for your work when you're working with community partners?
See how best to answer the question about challenges. Kim, as a social worker, there's a concept called community organizing and community planning and community development. These are three strategies that social workers use when they engage with communities. And I have used community organizing and community planning strategies and skills when I interface with any new community. And it has a set of tools you use. And one of them is to be a fly on the wall. When you enter a new space, to be a fly on the wall and just observe. You know, you don't start building, you don't start partnering for either research or projects till you've built a relationship, which takes months, sometimes years. Then second is building trust. First a relationship, then a trust. And then beyond trust, after first step, beyond trust, if you're invited to that group to engage with them either for research or for a project, that's when the door is open for you. So very seldom do I go in and say, I have an idea, will you partner? It is built on, that was my original goal when I started working in behavioral health, was, you know, grantors are asking for more and more collaboration across disciplines and with communities. And I was preparing the ground for having these relationships in place years before applying for grant. I started building relationships 10 years ago, Kim, and I just 3 years ago started applying for grants. That tells you how long it takes. And now that there's traction, now we can springboard. But you don't walk in with wanting to write grants with community partners from day one.
That's a really good point. Yep, really good point. So I guess the time consuming piece of it is a little bit of a challenge at times then. Yes.
If you want sustainable partnerships and write grants with these partners for an extended period of time, rather than what I think in public health you call onesies, one-offs, no, there has to be a track here, and the track should go upstream, downstream, diversify. But not just one-offs. One-offs takes no one nowhere. It keeps you busy for 3 years and then you're done.
Yeah, good question, Kim. And I agree that when you have collaborations with the state health department, as an example, once they know you as a credible partner and that they trust you, that means that they're always going to come back to you. So you kind of get that pipeline going, and it continues for as long as you continue to do the research. So great. So we have another hand up. Lawrence, go ahead.
Hello, everybody. Lawrence Bryant here, part-time faculty, Kennesaw State University. I've been in healthcare for, I want to say, almost 50 years, and I know I'm aging myself. But through that process, there have maybe been 3 or 4 people, women particularly, who have totally and unequivocally inspired me. And you are one of them. Working on the multicultural project has been just a great learning experience, but it's been a great experience just in terms of insight and knowledge provided by you. So here's my question, because we worked together probably about 4 or 5 years now on the multicultural project, coming to teach your class in terms of issues around substance use disorder. But one of the highlights of our multicultural research was design thinking. And when I think about that, I just consider you as just really being a pillar in that particular genre. So my question is, how can we take that intervention, which I think is so evidence-based, I think it's so, so much something that really provides a more in-depth look at behavioral health. How can we take that to the next level in terms of research, in terms of publication, just in terms of disseminating this powerful intervention in terms of behavioral health?
Thank you, Lawrence. So I'm going to answer your question. Let me just give a bird's eye view 101 to the audience on what is human-centered design thinking. So human-centered design thinking is a research methodology. There are about 150 kinds of research strategies inside human-centered design thinking. And the way the data collection is and analysis is built is that you go to the consumers or your subjects with truly, once again, a very humble and not the typical researcher orientation, like I know what questions to ask you and I would like for you to check the box. That's not how you approach the audience, the audience as well as the participants. You approach them with complete humility. And the way they answer the questions is not in the typical way. They don't answer questions by checking boxes or you transcribing qualitative data. The way they answer questions is generally by using 2 to 3 words to any question you pose them, 2 to 3 words on sticky notes, and they can give as many answers as they want for the time you've given them to write their answers. Then we invite them, the participants, to group all the responses of all the participants into categories and label it so that this gives content validity to what data we are collecting. We are not interpreting anything. It's their data, they categorize it, they draw lines between, if you're doing journey mapping and the journey that people in recovery have traveled, they draw lines between the categories. This is what happened to us first, then this happened, then we went for information over here. This was our experience. So they literally tell the entire story in 2 hours, their life story. And one other element about design thinking is that the consumers who are experiencing the problems, challenges, also know the answers. So you ask them what we call the magic wand question. If resources were no bar and you could fix or improve your experience in whatever the topic may be, how would you improve it? So we ask that question of the participants. That is what has been used in much of our research to design strategies and policies in the nonprofit as well that we mentioned earlier. Now, to answer your question, Lawrence, as to how to use this technique for improving behavioral health, I think there's so much diversity in Georgia, rural, urban, suburban, all the cultures that exist, that doing research using this technique, which is very culturally humbling and culturally sensitive, this technique can be used by somebody who doesn't speak English. They're using 2 or 3 words. So it's very culturally appropriate as well. Using this technique to collect data from diverse groups, and that guides the development of the behavioral health system, would be the ideal. Thank you. Thank you, Lawrence, for that question.
Excellent question, Lawrence. Thank you for that. So again, audience members, please feel free to put a question in the chat function or just raise your hand. Yeah, I was just going to ask you, Kim, if you had another question, but your hand just came down. So Monica, I'm going to jump in with a few questions about the research that you presented in the video. So this question relates to the health-seeking behaviors study that you did with college students. And you mentioned several different groups maybe this isn't the college student one, but you mentioned several different groups: veterans, LGBTQ, Latinx. I'm wondering if in those health-seeking behaviors, you could tell us about what differences you found between those populations.
So Fedra, the help-seeking behaviors was with college students, and there we had gender. We identified gender as one of the variables, and race and age. Those were the 3 variables that we identified. And I'll tell you the difference between African Americans and Caucasian students, as well as age of the student. So the difference, very interesting differences. First and foremost, what was surprising is that students of all ages turn to family and friends first for any information and help related to behavioral health. 75% turn to that family friend group first. And what blew us away, if Brian is on this call, Brian Culp, what blew us away, only one, and Dominic is on this call, 1% go online. 1% of the sample went online to look for help. And look at the amount of money we spend in online resources, right? That was eye-opening. The second thing we found is that age group 41 to 65, I'm going to refer to my notes if you don't mind. Age group 41 to 65 are more likely to seek professional help than any other age group. Professional help. They will seek counselors. What else we found is females are also more likely to seek professional help than males. This was interesting. Males are more likely to go to families and friends for help than females. Now, what was really not surprising and surprising at the same time, white females and African-American males. White females and African-American males are more likely to go for professional help than white males and African-American females. Now, the question is why? when you look at that difference, I don't know the reason why, but I'm hypothesizing that matriarchy, patriarchy, which generation, which gender in what race has to be strong, appear to be strong, not macho, but strong and not need help, and I can pull myself up my bootstraps and I can handle it and this will not get to me. I think that may explain why we noticed the difference that we did.
Very interesting. And so, I'll ask you the so what's next question, or so what does this mean if I'm a provider, like we're in the USG, we're self-insured, we have the accolade, and we have all of these online systems that should be available to us if we have mental health problems. What would your advice be if it's family and friends? How do providers get to the people who need the help through family and friends?
So there's a movement, and you may have noticed it. There's a movement developing both in the mental health and the behavioral health space, Fedra, and especially in youth as well. Peer mentors, peers is becoming more of a shouldn't say norm, but more common today than it was even 5 years ago. So even at Kennesaw, we have a mental health initiative funded by USG, and the money came from the governor for supporting mental health of college students. And we have hired peer mentors even at Kennesaw. I'm sure that's the case across the USG system. So hiring, training peers, especially peers, while you're talking about college campus context. And then with family members, I think when we do orientations, when we have events for parents and friends to come to campus, putting resources in the hands of people who visit campus in a very non-threatening, non-stigmatizing fashion. I think that I don't know how to do that yet. I mean, that's a skill unto itself. How do you put resources about a stigmatized concept in the hands of neophytes and people who are not very conversant in that space? That's an art and a skill. We have a long way to go in how to do that correctly. I don't have an answer, but it needs to be done.
Incrementally, we're getting to the answer, right? So we're talking about help seeking. So we're talking also about the recovery journey. And I think in the video I heard you mention the recovery journey specifically around opioid usage. And I'm wondering if you could tell us a little bit about some cultural differences and what a recovery journey might look like.
So we did human-centered design thinking, data collection techniques. We did it with veterans, population that is unhoused, African Americans, Latinx, college students, and elderly. And a common theme across all of them, I'm going to get to the differences in a minute, a common theme across all of them was emotional pain and emotional trauma. That's how they all began their journey. The differences that we noticed were the pronounced differences were between LGBTQ plus population and everyone else. And the main difference was when I heard one of the participants say in the LGBTQ community, I'm sorry if I didn't mention that earlier, was that we have come, these were non-HIV positive individuals, and they were talking about their recovery journey and how traumatic and painful it has been for them because of the judgment, the judgment that the provider community places on this population, one, and second, if they have substance use disorder, right? You combine the two, it's like a double whammy for this population. The stigma is unbelievable. So they talked about the stigma and the disenfranchisement that they experienced. We didn't hear that much from other subpopulations that we spoke with. Number one. Number two, what really blew us away, and Lawrence can testify to that, one or two participants said, you know, because we are HIV negative, we don't get access to anything. And we have sometimes thought about even getting infected so that we would get resources. I mean, can you imagine somebody saying that to you?
Amazing.
Because they're negative, they are not getting help. That blew us away.
So let's explain that for our listeners, because maybe not everyone understands that if you're HIV positive, you have what? Free access to services, right?
And housing is a big one. See, many of these individuals are unhoused, and they struggle while they're recovering. Employment and housing are major hurdles. Now, if you're HIV positive, and accessing treatment. If you're HIV positive, you may have a slightly easier time accessing these resources and services. With HIV negative, the roads are closed for you. So that, and the fact that somebody who has made sure that they're HIV negative to remain HIV negative is entertaining that thought just to get access, actually brought tears to all our eyes. Absolutely. We didn't realize the intensity of the problem they were experiencing in their recovery journey.
And so with the 1013 legislation here in Georgia, will that help the problem a little bit? Because my understanding of the legislation is it's health insurance parity, but that doesn't necessarily mean that I'm going to have, if I have no health insurance, that I'm going to have access to anything, does it?
So if it's health insurance parity, let's say you're Medicaid eligible, right? So you were getting Medicaid if you were so if you're uninsured and Medicaid, if you have Medicaid, hopefully Medicaid that provide physical health coverage will provide better mental health coverage funded by Medicaid. That's the hope and prayer, right? But as you know, Phaedra, when a law is written, by the time the regs get written, so much can be lost in translation. And by the time implementation happens, so much more can be lost in that translation. So the law can be ideal, but the way we have to now also advocate, like we advocated for 1013, we have to advocate when the regs are being written as well, to make sure that the intention of the law is there, and then work with people on the ground floor who are implementing it to make sure that people, LGBTQ trans, are not given the runaround. So you could be given a runaround too, right? When you're trying to access. That does not happen. So the advocacy journey doesn't stop when the law is passed. It continues till implementation and evaluation.
Mm-hmm. I could ask so many more questions on this, Monica, but I want to go back to the research that you're doing on the first responders. So you talked about how the coding is different between the different providers, like police and fire, as an example. So in this research, which is so critically important that you've identified these differences, what do you do with these data? I heard you say that the state would love for you to do this across the state, but they don't necessarily have funding to do it. But what can you do as a faculty member, as a researcher, to try to get some changes in the coding across these units? What steps do you take beyond just publishing in a peer-reviewed journal?
So 911, fire, and police are our partners, and they realize they work in parallel universe because their CAT system, their recording system, their reporting system don't talk. They are different languages, they are in different systems. We are hopeful that with the way we want to conduct the analysis, that our modeling, the neural network analysis system, the algorithms we are building, will be able to predict not only the mental health cases on historical data. Our goal is that they are able to predict, once we build this model out, because neural network analysis allows analytical tools to get smarter each time you run it, right? It's getting smarter. So our goal is to have it predict need for mental health follow-ups or a different response system in real time. So in an ideal world, the moment a 911 call is made and a few words are used, if this analysis is integrated, the algorithm is integrated into the data management system for 911, that it alerts the necessary parties. This is a mental health call. This is what needs to happen, because currently, Fedra, you know what is happening with all mental health calls? Police goes there with their car, EMT goes there with their ambulance, and a fire. You've got at least $5,000 to $10,000 worth of equipment and human power going out for a mental health call. That's a lot of wastage of county dollars, a lot. And so we want to present this finding, that was the original goal, to the county commission to share the amount of wastage of county dollars when these three engines are going for a mental health call.
Excellent, excellent. We're almost out of time, but I see Dean Swan has her hand up, so we'll turn it over to you, Monica.
Well, I just wanted to, I know you're just about to wrap it up, but I just want to say congratulations to Monica. We are so thrilled about your work. You're such a great ambassador, not only for mental health, but for KSU. And I think Lawrence might have just said it best a moment ago. I think many of us see you as a huge inspiration, not just for your energy, but for your interdisciplinary, transdisciplinary work. And I think the questions that have been raised today really outline how important this topic is to many of us. And I think we just need to think of more for us for how we can explore next step and really to talk about the impact your work is having. So congratulations to you. So glad that you did this research with Relevance for us.
Thank you, Dean Swan. Thank you for the opportunity.
Yes, well, thank you. Thank you to both Monicas on that one. I agree that this is such an important area of research that crosses not just faculty member in Wellstar, but faculty members in the Radau College and other faculty member on campus. I think it's a good example of perhaps a research center that should be built up around this topic someday in the future. So with that, I'm going to wrap us up. Again, a big thank you to Monikanandan for her time today. I want to also thank Megan Lowney, who is our wonderful StratCom person who spent a lot of time working with our featured presenters to develop the videos and to keep us all on track. So thank you to Megan. I want to say that it's been a pleasure to host Research with Relevance this semester. We made a point to feature our chairs and deans, and it has been, I think, just a wonderful contribution to the Research with Relevance Friday features in general. We are going to take a break from Research with Relevance over the next couple of months, so we encourage you to stay engaged with our office through our website and also through social media. We try to be as active as possible, and we will be coming back to you in the fall with a Research with Relevance show of some sort. We are in the process of reimagining what that platform looks like. And so if you have some ideas that you would like to share with us or feedback, please feel free to reach out to Megan. And so with that, a big thank you to all. We hope from the Office of Research you have a wonderful, safe, and healthy weekend, and we'll see you soon.